Welcome to The Explainer. Okay, let's just dive right in today. We are looking at a really classic clinical diagnostic trap, one where your trusty stethoscope might actually lead you totally astray. We're going to explore the post-resection chest, and we're building it from the ground up, entirely from first principles. Because, in clinical medicine, relying entirely on old school textbook assumptions, well, it can sometimes cause you to miss the most critical piece of evidence that is literally hiding in plain sight. So imagine this. You're examining a patient's chest. You place your hands on their back, you listen, you tap. And what do you find? Dullness to percussion, significantly reduced breath sounds, and a trachea that is distinctly pulled off to one side. Now, every single one of these physical findings points, pretty convincingly, toward lobar collapse, right? You might even feel ready to present your diagnosis with absolute confidence. But I've got to ask you, what condition perfectly mimics lobar collapse to the point of being almost indistinguishable?
The answer is surgically absent lung. You might actually be dealing with a patient who's had a pneumonectomy or a lobectomy. And missing this, it doesn't just mean you got a trivia question wrong. It represents a genuine category error. You are literally mistaking surgically missing tissue for diseased, collapsed tissue. It's kind of like calling a parking lot a collapsed building. And what makes this so fascinating and honestly so dangerous for the unwary clinician is that these two completely different realities produce an almost identical physical signature. Section 1. The trap and the physics. Why absence and collapse look identical. To really understand this trap, we have to look at the core mechanics at play inside the chest cavity. And this comparison brilliantly illustrates the core insight. On the left side, you've got lung tissue that is essentially missing from the respiratory equation because a bronchus is obstructed, so that's your true collapse. But on the right, the lung tissue is missing because a surgeon's scalpel removed it. But structurally, inside that rigid box of a thorax, the resulting physical findings are driven by the exact same mechanical factor. And that factor is reduced lung volume. That's the crucial point here. Reduced volume on that side of the chest is what fundamentally drives all your physical findings. Think about it. The chest cavity is basically a sealed vacuum. So when a massive amount of volume is suddenly just no longer occupied by aerated lung tissue, the local anatomy has to adjust to fill that void. That incredibly simple concept of volume loss, that is the engine behind every single finding you're noting at the bedside. Mechanically, this vacuum effect is the culprit behind it all. It literally yanks the trachea toward the empty space as a totally natural consequence. It creates that dull percussion note and dampens those breath sounds because, well, the resonant, airy lung is just gone. And crucially, the chest wall actually caves in to settle into the void, which creates this visible asymmetry. Because the mechanics are identical, the clinical sound and feel are, you guessed it, absolutely identical. Section 2. Hunting for the scar. Your single most important piece of evidence. Because these two conditions sound remarkably identical, your entire diagnosis really hinges on just one clue: the scar. If you don't intentionally look for it, you are going to miss the diagnosis completely. But here is where we absolutely need to update older teaching. For decades, medical textbooks have taught us to look for the classic large lateral thoracotomy scar. That large incision sweeping right across the ribs. But you can't anchor your scar hunting purely on a large lateral thoracotomy anymore, because surgical techniques have evolved decisively. If you only look for that massive textbook scar, you're going to misdiagnose modern patients. We have seen a massive shift toward video-assisted thoracoscopic surgery, or VATS, and increasingly robotic-assisted thoracoscopic surgery. Actually, in the United States today, more pulmonary lobectomies are performed robotically than through traditional open surgery. So what does this mean for you at the bedside? Well, it means the patient in front of you might only have a tiny, easily missed cluster of port site scars. These tiny little marks are the only external clue that a massive internal anatomical change has even taken place. Section 3, the usual suspects, breaking down surgical indications. Okay, so once you spot that modern port site scar, you have to ask yourself why it's there. And age and history do the heavy diagnostic lifting here. If you see a younger patient with a resection scar, your mind should immediately jump toward a carcinoid tumor, which tends to present earlier in life, or maybe surgery for localized bronchiectasis confined to a single lobe. Conversely, an older patient strongly points toward lung cancer, especially if there's a smoking history. Or, and this is a really fascinating one, it could be the legacy of historical pre-antibiotic era tuberculosis surgery, back when physically cutting out the diseased tissue was a primary treatment. You should also definitely keep decortication for empyema in mind.
This involved a surgeon going in to basically strip away a thickened, infected pleural rind to let a trapped lung re-expand. Sometimes if the underlying lung tissue is irreversibly damaged by the infection, they actually have to resect that tissue at the same time. It's another classic reason for finding those surgical scars on the chest wall.
Section 4. The modern twists. Evolving standards of care in lung surgery.
Just as incisions have gotten a lot smaller, the amount of lung tissue surgeons are willing to sacrifice has also drastically changed. Historically, finding a centrally located tumor meant taking out the entire lung, a full pneumonectomy. But today, surgeons increasingly favor lung-sparing sleeve lobectomies whenever it's technically and oncologically feasible. Think of it kind of like taking a damaged section out of a pipe. They remove the affected lobe, along with a segment of the main bronchus, and then directly reconnect the remaining healthy airway.
And this matters immensely. By preserving that healthy lung tissue, rather than just unnecessarily sacrificing it to a full pneumonectomy, patients experience much better long-term survival rates and significantly lower perioperative mortality. A full pneumonectomy is no longer the default answer. It's now the fallback option, really only used when these incredibly sophisticated lung-sparing techniques have been entirely ruled out. Section 5. Life after pneumonectomy. Understanding physiological margins.
Now, when a full pneumonectomy genuinely is the only option, we have to remember that the physiological margin for error becomes razor thin. Removing an entire lung is a massive physiological event. The body doesn't just leave an empty cavity there. Over months, the remaining lung, the mediastinum, and the diaphragm all gradually shift and compensate to fill that resulting space. Because the patient's entire respiratory function now depends completely on a single lung, this is exactly why a strict multi-step assessment sequence is universally required. We use pulmonary function testing, DLCO assessments to check gas exchange, and formal cardiopulmonary exercise testing to guarantee, long before the surgeon ever makes a cut, that the patient has the physiological reserve to actually survive on one lung.
Section 6. Pulling the picture together. Your post-resection clinical checklist. All right, so now that we understand the physics and the scars, let's review your bedside checklist so you can assess a post-resection patient with total confidence. Honestly, your post-resection checklist essentially mirrors your collapse checklist. You look for the depressed chest wall asymmetry, you confirm the trachea is deviated toward the affected side, you feel for reduced chest expansion, percuss for dullness, and auscultate for reduced breath sounds. The absolute key differentiator here is the territory. See, in a lobectomy, these findings are confined to a specific area, often with the adjacent remaining lung showing compensatory hyperinflation. But in a full pneumonectomy, you will see this exact clinical pattern dominating the entire hemithorax. So, to wrap up this explainer, the next time you find a collapse mimicking signature, remember to really, truly look at the skin. Do not let your ears override your eyes. The single clue that solves the mystery, whether it's a massive open thoracotomy scar or a tiny faded robotic port site cluster, is often sitting right there in plain sight. It really makes you wonder, what other classic diagnostic assumptions are you making right now that modern medicine has already silently rewritten?